Okay, so let's start with this with the PPT, and then meanwhile we can discuss things out. So as Dr. Harpreet and Dr. Sanjeev said, that diabetes is a group of diseases. It's not just one disease; it's a group of diseases characterized by high level of blood glucose resulting from defects in insulin production or insulin action or both. Come to the characteristic features. So in type 1, so we know majorly there are two types of diabetes. However, there are many subtypes. Subtypes are gestational diabetes, type 3C, which is pancreatitis, and again, secondary diabetes caused by various other anomalies, and of course, MODY and LADA, which is ultimately kind of type 1 diabetes. So in type 1 diabetes, the features will include polyuria, polydipsia, that means increase in urinary frequency, increased thirst, increase in nocturnal urination or nocturnal enuresis, weight loss, failure to thrive, loss of appetite, lethargy, dehydration, headache, constipation, abdominal pain, which may cause diaper rash, and again, vulvovaginal candidiasis in teenagers. So fungal infections are very common, especially in females. So vulvovaginal candidiasis again, and a common kind of complication which happens in type 1 diabetic females. In type 2, it is typically polyuria, polydipsia, weight loss, lethargy, headache, progressive loss of vision, giddiness, paresthesias, muscle aches, cardiorespiratory complaints, non-healing wounds and ulcers, impotency, and again pruritus. Impotency is one symptom which generally we should ask in our history to all type 2 diabetic patients. In some patients, probably in type 1 also in late. What is the reason of impotency being common in okay? Would anyone else like to answer that? Okay. So again, neuropathy. So neuropathy is also one case, one reason for erectile dysfunction. So erectile dysfunction generally leads to impotency in males, and that is so there are many patients which we see with EDs coming to us and complaining of EDs who has already developed moderate to severe neuropathy. If we treat neuropathy, EDs reverse in general. So again, those patients do not get better with sildenafil or tadalafil. Ultimately, it's the neuropathy which is causing erectile dysfunction. And once that gets treated, erectile dysfunction gets better. So again, people with diabetes has an increased risk of cardiovascular, peripheral vascular, and cerebrovascular diseases. If we talk about burden of diabetes, it's actually growing on daily basis. So as per the last IDF, so the numbers will reach about 333 million by 2025. Insulin secretion is very rare, but yes, there's generally partial insulin secretion, or when it develops, when the body's immune system destroys the pancreatic beta cells, the only cells in the body which ultimately secretes the hormone insulin. So again, this form of diabetes usually strikes children and younger adults, although disease onset can occur at any age. As I said before, if it's a delayed onset, or probably if it's a delayed diagnosis, the patient generally lands up in the emergency department with HHS or acute hyperglycemic state. Now again, type 1 diabetes is majorly 5 to 10% of our whole practice of the patients which we see throughout the world. And, right? As the need of insulin rises, the pancreas gradually loses its ability to produce insulin. So this is there are two factors. One, because the load on pancreas keeps on growing, so ultimately their action keeps on depleting. One. Second, in elderly patients, because of senile defect, it ultimately loses its tendency to probably gradually loses its efficacy in producing insulin. So again, it is associated with older age, obesity, family history of diabetes, history of gestational diabetes, impaired glucose metabolism, physical inactivity, and again, race and ethnicity. We are probably one of the most prominent races to get diabetes. With us, it's African Americans or Hispanics. So again, type 2 diabetes is increasingly being diagnosed in children and adolescents also. So as I said, the age which was 40 before has now again, that's the insulin pathway. So basically, the insulin breaks the glucose in the muscles. Blood glucose levels fall, and again less insulin produced, and ultimately leads to homeostatic disturbance. Again, in liver, it converts the glucose to glycogen, fats, and proteins, which ultimately again cause glucose levels to fall. If the less insulin produced, homeostasis is disturbed. The beta cells release, so it's a complete pathway going from pancreas to muscles and liver, and then again the homeostatic. And then again, because the insulin levels are falling, the glucagon levels go high, and ultimately causes high blood glucose levels. So the normal blood glucose homeostasis, as you can see, is basically ranged to high and low, which ultimately causes glycemic variability or blood glucose fluctuations. The more are the fluctuations, the more will be the HbA1c. It's as simple as that. Please tell me if there's any confusion over here. Diabetic in the next 5 to 10 minutes. So hence the cycle keeps on going. So during pregnancy, gestational diabetes requires treatment to normalize blood glucose levels to avoid complications to the infant. So it's both for infant and for the mother. After pregnancy, 5 to 10% of women with gestational diabetes are found to have type 2 diabetes. However, women who have had gestational diabetes have a 20 to 50% chance of developing diabetes in the next 5 to 10 years. Diabetes of youth, surgery, drugs like corticosteroids and others. So I'll take them afterwards. Malnutrition, infants with Kwashiorkor, they are more prone to get diabetes. Infections, we also, so again, and illnesses. Those patients are more prone. IGT, IFG, and metabolic syndromes. PCOS, so polycystic ovarian syndromes, it's already a pre-diabetic condition. So those patients are very high risk because of. And why is PCOS patients more risk to at a higher risk of having diabetes? Can someone tell me? Decarboxylase antibodies, so again pancreatic beta cell antibodies and zinc transporter. This may occur in overweight or obese patients as well as lean individuals. So it's not specific, but generally, so this may not be specific to the case. Talking about prevention or delay of diabetes, so again, lifestyle modification, that's the first thing. That's the only thing which we prefer. When we talk about lifestyle, so again, there has been multiple studies, and when we talk about lifestyle intervention, so again, it includes diet and moderate. I mean, what is the guideline? How much workout should one do in order to prevent or probably delay prevent diabetes or probably delay complications? It should be around 150 minutes a week, more than equal to 150 minutes a week. That means one should exercise around sugar twice a day. On Monday, he checks the sugars on fasting PP. Tuesday, he can check fasting bedtime. Wednesday, he can check fasting or probably 3 a.m. Why am I saying fasting? Because where does the problem lie? It's a fasting sugar, no? Right? Your PP is 135.